Hello there, my name is Luke Wells and I'm a 4th year medical student at Peninsula Medical School. This is my video on arterial blood gas analysis in a nutshell, and I hope you find it useful. Now what I've given here are the 3 most important normal ranges on an arterial blood gas analysis form. And these are the 3 that you'll be looking at to determine the nature of the patient's acid-base imbalance. The first is the pH, which has a normal range of 7.35 to 7.45. The next is the PaCO2, the partial pressure of carbon dioxide, and the normal reference ranges given for this are 4.7 to 6.0 kilopascals. And finally we have bicarbonate, which has a normal range of 24 to 28 millimoles per litre. So remember these 3 normal ranges, as they are the 3 most important ones that you need to know when analysing an arterial blood gas. This is how a typical arterial blood gas result will be given to you on the ward in the hospital. As you can see, at the top you have the pH, the PCO2 just below it, and 2 below that you have the HCO3, and as I mentioned before, they're the 3 that you really want to be looking at. Step 1 of ABG analysis is to look at the pH and ask yourself, does the patient have acidemia or alkalemia? And as you may or may not know, the suffix emia refers to the blood, so acidemia means acidic blood, alkalemia means alkaline blood, and you work this out by looking at the pH. Is it above or below the normal ranges? If it's below, the patient is acidemic. If it's above, the patient is alkalemic. So far, fairly straightforward. Now, if the patient has an acidemia, the process causing that is an acidosis of some sort. If the patient has alkalemia, the process causing that is likewise an alkalosis of some sort. So just to give you 2 examples of this, if you look back and think about what the normal pH ranges were, 7.35 to 7.45, if you're presented with a pH of 7.33, you have a low pH, therefore you have a patient presenting with acidemia, and this is caused by acidosis. If you have a patient with a pH of 7.49, this is above the normal range, therefore you have an alkalemia caused by alkalosis. Step 2 is to look at the PCO2. This tells you about the respiratory component of the patient's acid-base imbalance. And the way to remember this is that CO2 is part of the air that you breathe out when you exhale. And a higher than normal PCO2 is generally associated with an acidosis. And the way to remember this is to think of a fizzy drink. Now, a fizzy drink has carbon dioxide dissolved in it, and that gives it a slightly sour, sort of acidic taste. So, if you remember it like that, you'll be fine. Now, go back to your normal ranges and ask yourself, is the PCO2 high or low? And now you want to ask yourself, does the PCO2 explain the underlying acid-base imbalance? As I said before, a high PCO2 is associated with an acidosis, a low PCO2 is associated with an alkalosis. So does the PCO2 level correspond with what you found in step 1? And if it does, then you know that the patient's acid-base imbalance is due to a respiratory abnormality. Step 3 is to look at the bicarb, and this tells you about the metabolic component. Now, a high bicarbonate is associated with an alkalosis, and the way to remember this is to think of bicarbonate of soda, which is alkaline. And as you can see from the equation below, bicarbonate is a very important part of the body's acid-base homeostasis, the physiology of which is beyond the scope of this video. Back to your normal ranges again, ask yourself, is the bicarb high or low? Now, as with PCO2, you want to determine whether or not the bicarb level corresponds with the patient's acid-base state. And as I mentioned before, a high bicarb level is associated with alkalosis, think of the bicarbonate of soda. A low bicarb level is associated with an acidosis. Now it's time to do some practice questions before moving on to the next stage. For each example given, I want you to write down whether it's an alkalosis or an acidosis, whether the cause is respiratory, metabolic, or mixed. Feel free to pause the video at any time. Have you worked it out yet? In question 1, we had a low pH in ACIDaemia, along with a high PCO2 and a normal range bicarb level. This gives you a picture of respiratory acidosis. In question 2, we had a high pH in alkalemia, along with a low PCO2 and a high bicarb level. This gives you a picture of a mixed alkalosis. Remember when I said before that it is possible to have a mixed picture. Now that we've covered the basics, I'm going to talk to you a little bit about compensation, and no, I'm not talking about that kind of compensation. Now, the easiest way to explain compensation is that the body is compensating for an acidosis or an alkalosis, be it respiratory or metabolic, by carrying out the opposite process at the other end of things. So, say you have a respiratory acidosis going on, the body will try to compensate for this by inducing a metabolic alkalosis. Remember what I said earlier about acidosis and alkalosis only being processes. So following on to your stepwise approach of ABG analysis, there are 3 more rules to consider. Rule number 4, compensation is an opposing mechanism. What I mean by that is if the primary mechanism is respiratory, then your compensatory mechanism is going to be metabolic, and vice versa. Rule number 5, the body never overcompensates. And what I mean by this is that the compensatory mechanism will never push the pH of the blood past the normal range. So if your primary process is an acidosis, the compensatory process will never push the blood into an alkalemic state. And rule number 6, compensation may be complete or incomplete. And what I mean by this is that if you have complete compensation, you have a pH within the normal ranges. Incomplete compensation means the pH is still outside of the normal range. That's all that means. Now what I'm going to do is I'm going to run you through one example just to help you clarify things in your mind a little bit. So in this example, we have a pH of 7.47, a PCO2 of 3.2, and an HCO3 of 15. So we're going to work through this example stepwise. Now first of all, we want to look at the pH. Is it high or low? Go back to our normal ranges and we'll see that actually the pH in this case is slightly raised, which means we have an alkalemia. Then we move on to the PCO2. Again, go back to the normal ranges. A PCO2 of 3.2 means that the patient has a low blood PCO2 level. So now we ask ourselves, does this fit with the patient's acid-base imbalance? Yes, it does. A low blood PCO2 is associated with an alkalemia. So what we have here is a respiratory alkalosis. Now we want to move on to the bicarb. Is the bicarb high or low? Again, go back to our normal ranges. We'll see that the bicarb in this case, 15, is in fact low. A low bicarb is associated with an acidosis, so what we actually have going on here is a process opposite to the primary process that is causing this acid-base imbalance in the first place. And since we've already decided that the primary process is a respiratory one, we can therefore come to the conclusion that the low bicarb is part of a compensatory mechanism to bring the pH closer to a normal range. However, as the pH still falls outside of the 7.35 to 7.45 normal range, we can say that this is an incomplete compensation. Therefore, what we can say about this patient is that they have a respiratory alkalosis with incomplete metabolic compensation. And now it's your turn. Run through a couple of examples yourself with what you've learned so far, and feel free to pause the video at any time. Now question 5 is a bit trickier. I've included the oxygen here, and if you can figure out the reason I've done that, then extra brownie points to you. If you can't, don't despair. I'll explain it to you in a bit. Now it's time to see how you got on. The answer to question 4 is an uncompensated metabolic acidosis. Did you get it right? If you did, well done. If you didn't, look back at the question and try and figure out exactly where you went wrong. The answer to question 5 is a respiratory acidosis with complete metabolic compensation. If you got this right, very well done. If you didn't, I'll explain the answer to you. Let's go back to the question. We have a pH within the normal range, but slightly on the low side. We also have a PCO2 of 8, which is raised. We also have a bicarbonate of 34, which is also raised. So in other words, we have a respiratory acidotic component, and we also have a metabolic alkalotic component. So what's going on here? What's the primary process behind the patient's pH? The clue's in the oxygen levels. the patient's oxygen level is low, which is suggestive that the respiratory system is not working as well as it should be. The patient may not be breathing as quickly, or they may be having difficulty in breathing, for example, in COPD. And this is the clue that would lead you to conclude that the primary process is respiratory, and therefore this patient is having a fully compensated respiratory acidosis. Well, this concludes my teaching on ABG analysis. I hope you learned something, and for those of you who have an assessment coming up, good luck and don't panic.